Hi guys, this is Deanne with Hope Point Myo. I wanted to do a quick video on children with sleep apnea or at least sleep disordered breathing. Some of the symptoms that you can see in that are if they wake up very regularly in the night or come to you thirsty or just can't sleep during the night. Others would be snoring or gasping, tossing and turning throughout the night. If they go to bed one way and they wake up all over the bed and their sheets or blankets are a mess, or for girls like their hair is all knotted. ADHD or ADD is oftentimes a symptom of that, and just behavioral issues a lot of times. For some, it can just be talking a lot. That was for me as a child, always talking too much. I got that on my report card. Bedwetting, like especially later on in years that they should be trained, but they're still bedwetting. That is very much a red flag that they could have sleep disordered breathing. Sleepwalking or sleep talking is a symptom. Weight gain can also be a symptom. Each one of these I could explain why, and maybe I can do that later, but just know there are slow growth, because that's when we grow, or children grow most of the time is when they're sleeping deeply, and low energy or just tiredness. Some can be, again, the hyperactive. Some can be just slow and low key or grumpy all the time. There's more, those are the ones I think I mentioned. Oh, grinding at night. That's a big one as well, grinding at night. So you could say, well, my child does one or more of these things. What do I do about it? I will say you could have a sleep study done, but sleep studies are meant for men. They're designed for men. They have done some minor adjustments for the children, but children can, and I've seen this in a video that I've watched in my training, children can compensate to get the air they need by like raising their chin and tossing and turning. That's why they're tossing and turning. And if they have a sleep study, they could pass it, but that doesn't mean their body is not struggling to sleep well or to get the oxygen they need. Also, it could be skewed. The results could be skewed. It could be that they're not looking at how much they're awake, but they're just looking at how much AHI or apnea-hypopnea indexes. Well, they might not have any because they're not in that deep sleep where they would have that. So they're not the most accurate. Sometimes just looking at symptoms, in my opinion, is the best way, because just knowing personally from family members who have had testing done as young children and told everything was fine, and it absolutely was not fine. But if your child has these symptoms, I mean, just know generally as a parent, something's not right here. So then you say, well, what do we do about it? I personally am not about testing, because I feel like they're not accurate. Some insurances may require testing for some of the treatments. Some of the treatments could be, a big one is surgery to have your tonsils or adenoids removed. That's huge, very helpful. Not always, again, I've seen this go bad where it did help initially, but then the adenoids grew back or enlarged, and that can happen if the function doesn't change. The thing that can cause them to enlarge to begin with is mouth breathing. If they're not trained to transition to nose breathe and just keep mouth breathing, then it can just go back to that problem. It is a quick fix, can be necessary for a child who needs help right away. If they're very enlarged, it is a good help for them. So the other options, sorry, my dog is scratching the carpet, trying to dig. Other options could be like upper airway meds, but they have proven to be very little help. They could have the surgery, different things like that can be helped for a while, but you have to change the function again from mouth breathing to nose breathing in order for that to be effective. You could do like PAP therapy, like CPAP, or they have BiPAP, things like that. I think it would just be for children, maybe CPAP or APAP therapy. The problem with that is if the mask, and I've experienced this for myself, the masks a lot of times are like this and they push on the jaw. Well, while a child is developing, when they're sleeping, which is when they develop the most, and especially at those ages, that's when they're rapidly growing. Well, when that's pushing on the jaw, it's just promoting even more the jaw to be back further, which is a huge leading to sleep apnea and sleep disordered breathing. So it's kind of counterintuitive. You're not really helping, you're causing more damage there. So ideally what you want to do is you want to fix the form or the just the structure that can cause the issues. A lot of times it's mouth breathing. Mouth breathing causes enlarged tonsils and adenoids because our noses were meant to filter all that out. When our noses aren't doing it, our tonsils are trying to do it, and it's more of a load than it can handle, so they get enlarged. But you want to fix that. So transition from mouth breathing to nose breathing, and you want to fix the structure. If a child has a small mouth, then they're probably going to have a small airway. So small mouth where you see crowding, narrow, just everything small. Then know that up here is probably small too, because it's all connected. I mean, it's all one unit. And so when there's crowding, you can pretty well bet there's going to be an airway issue there, and the child is struggling to some extent to sleep at night. So the idea is to get that expanded. When you expand the arch for the teeth to fit, you're not just making a pretty smile, or more making a larger airway, because it's the floor of the nasal cavity. So when you expand the mouth, it also expands the nasal cavity and allows more room there and better breathing. So then transitioning to nasal breathing is a whole lot easier. But because the child has mouth breathed most of their life due to allergies or other things, everything has just grown small. So you want to switch that back. But you've got to follow it form and function. Ideally, the function of the tongue shapes the form, because muscle versus bone, muscle always wins. That's where myofunctional therapy comes in. It trains the tongue to be up, which creates the form, but it also is nasal breathing, which has a lot of huge helps there too, like with the tonsils and adenoids, and just shaping the cavity, the whole structure, head structure, the way it's supposed to be. So if they're before 6 years old, whenever things are very rapidly growing, what we say, or what I've heard, is fix before 6 is the goal, to fix the function, so that from then on everything can grow the way it's supposed to. But for some children, you can't do that because it's already crowded. You've got to fix both. So that's where growth guidance appliances come in. That's where you have like the Myo Brace or Healthy Start, and there's a few others out there. Myo Munchie is somewhat, it's not made for the same purpose, but it can help as well. But they don't change or expand in and of themselves. They just help the tongue to stay up at the roof of the mouth and breathing through the nose. What myofunctional therapy trains to do, this just kind of backs it up and is kind of a passive exercise for that. And when the tongue is up, ideally, that naturally changes the shape. So the hope is to change the function with that, so that the shape will naturally change, but there's no guarantee that will fix it. Once you get to 6 years old, some dentists, orthodontists, airway ones, will do expansion before they're 6, if they're extreme, and that's an option. Those are hard to find. People are hard to find. But if you can find them, I've talked to one dentist, airway dentist, and they do them like as early as 3 years old. And the reason why they prefer that over the growth guidance appliances is because they say they know they will get the results they want. Whereas the growth guidance, it's a hope so, but not a guarantee. But it can be hard to find a provider who will do that. So that's up to 6. All this alongside with myofunctional therapy to train everything, the function to be correct. After 6, then you would pretty much need to do expansion, because by that point, most of the growth or the structure is set in a sense. There's still growing to be done, but as far as the fusion of the palate and everything, you'll need expansion to really open that up. And again, you don't want expansion with wires. My children had that, and it was incorrect. It did not expand the structure of the mouth. It just expanded the teeth and flared them, and so everything stayed small, and their airways are small still. So when you have expansion, you want it to be in the middle of the palate, expanding out. And also they can do expansion on the lowers when they're younger, on the mandible, which it's like, get it while you can, because once this is done, there's no way to expand it after that without surgery. So the younger you can get this, the better. There is a window of time after 6. Well, once they're 6, when they have the 4 permanent anteriors and then their first molars or second molars, the first set of molars that come in, that's definitely a time that you can do the expansion with a palate expander, and that's an ideal time. Once they start getting their permanent teeth along with their baby teeth, it's harder to do the expanding just because there's so much going on, and that's a window of time where you've lost, and that could be about 10, 11. It just depends on the child and how much the permanent teeth are coming in and the baby teeth roots are gone, because you can't move the baby teeth if the roots are so short. And you just have to wait till the permanent teeth get settled to move those. So once they get to that certain age, maybe 12 years old, when the permanent teeth are in, you can do palate expansion again. They call it rapid palate expansion. After that, there becomes a certain, when they're older, like older teen or past that, into adults, you can do what they call a MARPE, which is a rapid palate expander, or palate expansion, except they have to set screws into the palate, which sounds like a big deal, but they're little screws, but it joins onto the bone there so that when it splits, it can split that midline suture is what it's called, where the palate comes together. It's fused together, but when you do the screws in there, it provides enough force that it can split that, and then bone will remodel or fill in and grow into that to grow. That's personally what I need to have done for my palate because it's so narrow and my airway is narrow. So those are options that you can do. Again, with all this, you need myofunctional therapy because, again, you have to change the function also. You can't just change the form. And once you get the form set, you want to have the function set too so that it doesn't just reverse or continue to cause issues. So if you have any questions, you can just comment below and I will do what I can to answer, and hopefully more to come on kids.